Welcome back to the second half of our program. All right. Tonight, and I lost my place, we'll be here. So our second speaker is on the subject of depression, not autism, though she could speak on autism, maybe another time. Suruchi Chandra, Dr. Suruchi Chandra, is a board-certified psychiatrist who uses an integrative and holistic approach to help children and adults with challenging psychological and behavioral issues, including autism spectrum disorders. That's what threw the autism word in my head. Obsessive compulsive disorder, chronic fatigue syndrome, and mood disorder. And I think I'll leave it at that and let you take it from here. Welcome.
So it's great being here because I just opened my practice about a block down. So it's nice to be able to share this with the community, the work that we're doing. So we're going to talk about integrative approaches to depression. And first we're going to talk about the current model of depression, how most of us understand it. And we're going to look at how the current model, which is centered on serotonin, is inadequate both for understanding depression and treating depression. And then we're going to look at a more integrated, complex model of depression. And then thirdly, we'll look at how this model opens up the venue and paths for other treatments and really offers hope for those people who haven't responded to SSRI medications. So how do most people think of depression? Whether they're clinicians or patients, most people think depression is a deficiency in serotonin, which is a neurotransmitter. It's what allows neurons to talk to each other in the brain. So it's a deficiency in serotonin is the current model, and the SSRI medications prevent the uptake of serotonin, so there's more serotonin in the space between neurons. And the idea is that they can speak to each other. So that's how many of the medications that you've probably heard about work, such as Zoloft, Paxil, Prozac, Lexapro. Now the problem with this model, there are a few problems. One is that when we do larger studies, or what we call meta-analyses, and pull together all the studies that have been done on SSRI medications, they show that these medications, the SSRI medications, are no more effective than placebo for the vast majority of depressions. And this includes specifically patients who have mild depression and moderate depression. They found that these medications, some of the most widely used medications, are no more effective than placebo. And that the SSRI medications, when they are effective, seem to be effective primarily for patients with severe depression. So you have a large pool of people who aren't responding to these medications in meta-analyses. The other problem in this theory is that the SSRI medications take about 2 to 4 weeks to work at least, some people 6 weeks. Anyone who's taken these medications know that. They don't work overnight. But the medications address the serotonin imbalance within hours. So if primarily they were working by serotonin mechanisms, people should see improvement within hours of taking them, and that doesn't happen. So something else must be going on. And the other thing that's really important to know is that there's no body of research supporting that deficiency of serotonin causes depression.
Why did they start off with tricyclics that acted by a completely different mechanism?
We'll talk about that at the end.
These are new, so you're talking about the new theory.
Right.
But the old theory was totally different.
Well, they're all similar. They're all monoamine. So much of what I'm talking about also applies to that. And I'll address that at the end, but thank you for bringing that up. So now let's look at these medications because they do teach us something. So again, I said that when people do well with SSRI medications, it often takes about 4 to 6 weeks. So what's going on? So one theory is that it's placebo, and placebo may just take that long. But if it's placebo, it shouldn't be that standard. People should get better perhaps within a day or 2 days. So something seems to happen in those people who respond to SSRI medications around 4 to 6 weeks. Well, now we know research is showing that SSRI medications promote neurogenesis, which is the birth of new neurons, and that takes about 4 to 6 weeks. So it may be that when the SSRI medications do work, when they have effect, what they're doing is promoting neurogenesis. And these neurons regenerate primarily in a part of the brain called the hippocampus. And the SSRI medications also help the cells communicate, what we call synapses. So conventionally, we thought that you were born with a certain number of brain cells, and if something happened and you lost them, then there was no hope. But now we know in the field of neurology and psychiatry that the brain is actually much, much more plastic than we realized. And this offers a lot more hope for conditions. And we also know that the brain is constantly turning over neurons. So healing the brain and dealing with these disorders is more like tending to a garden and promoting this regeneration rather than just fixing a machine. So we can think of depression as a subtle neurodegenerative event. So we know that things like Alzheimer's and Parkinson's involve neurodegeneration, and depression, it seems to be, is a subtle, more mild version of neurodegeneration. And if this is true, then we might think that depression could be an early marker for other neurodegenerative diseases. And studies now are showing that if you're depressed, you're more likely later in life to have something like dementia. So if depression is related to failure of neurogenesis, of regeneration, there are many, many things that we know other than SSRI medications that promote neurogenesis. And they include things like fish oils, antioxidants, exercise. We talked about the antidepressants, even cognitive stimulation, and herbs, and diet. So it opens up the path for many, many other treatments. So we can think of healing depression and dealing with it not just as fixing a neurotransmitter, but really building resilience in a system, in a very complex system. So we think often when people have depression, we think, oh, you're just not strong enough, and you need to toughen up. And sometimes therapies are aimed at helping build better coping skills. But resilience in this case may not just be psychological resilience, it may be also physiological resilience. It may be that the system is not as strong, so this person can't handle the stress. So you can imagine if someone has heart disease and you put them in a stressful situation, you ask them to run up a hill, they get symptoms. You've stressed their system. So again, if someone has a weakness in their system, and we'll talk about the type of things that can cause weakness in the system, if you put them in a stressful situation, a situation where there's academic stress, job stress, financial loss, they may not handle it as well. And they may deem themselves as having a weakness or a flaw in character, but it may be more complex than that. So another thing that is important in understanding depression is it's not just something that's isolated in the brain often. So the brain is connected to all the other systems in the body. So if you have something that's affecting the brain, it could be coming from another system, such as the GI system or the immune system. And really, we should know this about depression because most people who have experienced depression say it's not just how I feel emotionally, it's how I feel in my whole body. I feel tired, I have muscle aches, I have stomach symptoms. I didn't realize depression is not just how I feel in my body. So it really is a whole body illness. And so we can see this new system or view of depression is that it's a cellular event, it's not just neurotransmitters. It's whole body focused rather than just the brain. And often multiple pathways and systems are involved. So it's more complex. But that also opens up the pathways for other ways of treating. So it's not just one treatment. And then lastly, in this new model, I want to propose that we should see depression as a symptom, not just a disease. So if you had a fever and you went to the doctor, would you be satisfied if they said, oh, you have a fever, take Tylenol, and told you to leave, and just suppress the fever? I hope most people wouldn't be. So what would you want? You would want your physician to figure out what's causing that fever, what's unique to you, to make sure it's not something that's life-threatening, and then ultimately to treat that underlying issue. So that's really what depression is. It's a symptom that there's something causing stress to the system more than it can handle. And that as clinicians, our job is to understand as much as we can, given our current tools, what those things are, to treat the symptoms first, and then over time, ideally treat as many of the underlying causes as we can. So what causes stress to this system? So most of us recognize that psychological or emotional stress can cause depression. So things like early life trauma, academic stress, those things can cause stress to the system and contribute to depression. But remember, if this is a physiological issue, other things that we don't primarily think of as related to depression may be involved. And these include things like chemical toxins, heavy metals, nutritional deficiencies, chronic infections primarily, not infections, but primarily chronic infections, and then other things that can cause stress to the system. And again, there are many, many pathways now in this model that are involved. There are many pathways that we know that can either promote neurogenesis or cause stress to the system. And I won't have time to go through each of these, but what I want to really impress on you is that it's not just serotonin. And this list is also incomplete. It's just a list of some of the things where there's evidence behind. So I'm going to talk about two systems now primarily because I don't have that much time, but these are two of the systems that often come up when evaluating and treating patients with depression. So the first is the GI tract. So we know now that the GI tract is very connected to the brain, and there's bidirectional communication. So both systems talk to each other. So if you have inflammation in the gut, that can actually contribute to or lead to inflammation in the brain. And the way that the gut talks to the brain includes a nerve called the vagus nerve, and you also have the immune system involved. And it works the other way too. If you have stress, many of us know this, it can lead to GI systems and even changes in how our GI system functions. The GI system is also very important because we have this very complex involved microbiome lining our GI system, and these are the thousands of different bacteria and yeast and even good parasites that line our GI system and that contribute to many things and functions of our body, including digestion, immune function, but also it looks like even brain development, mood, and our state in terms of anxiety. So when we make changes to this microbiome, it can affect brain function. So they found, for example, changing the microbiome can affect things such as serotonin, and something called BDNF, which is brain-derived neurotropic factor, which contributes to the growth of new neurons. So just changing the bacteria in the gut can do that. So this is important because on a societal level, we're doing so many things that are changing the microbiome. This includes use of antibiotics, putting antibiotics in the meat that we eat, the way that we handle sanitation. So we know that as a society, we've changed our microbiome. So we've changed how all of us are functioning in terms of brain function. And then clinically what I find is that the patients who've had excessive, what I call excessive, but maybe prolonged or frequent antibiotic use, that much of my time in helping them heal is spent on understanding what's going on in the microbiome and helping restore the microbiome as much as possible. So when I went to medical school, I didn't have much interest in the GI tract. I didn't think it was as complex or interesting as the brain. And the only reason that I spend so much time now thinking about it is because it's so, so critical in so many of my patients, but especially the patients where they've had the prolonged antibiotic use. The immune system. So again, we don't think of the immune system as really involved with depression. We think of immune system with infections or allergies, but not depression. But there's more and more evidence that the immune system is involved in brain function and depression and anxiety. Remember, the immune system is one way that our body, the outside world, communicates with the inside world. It's a signal that the immune system sends signals to the inside world about what's going on when we're exposed to things like viruses and bacteria, foreign food, and other things that may be foreign. So if you're exposed to a chronic infection, that can change the immune system and send signals to the brain. If you're exposed to foods that also cause the release of certain immune factors that cause stress in the system, that can affect brain function. So this is a study that was done at Johns Hopkins, and they found that in bipolar patients, that many of them had upregulated immune reactions to casein. Casein is the protein in milk. So they found that bipolar patients actually had increased IgG, that's an immune factor, levels when they ingested casein. And that also that of those patients who had bipolar, they're ones who had higher levels of antibodies to casein, they were more likely to have worse manic episodes. So that there might be some correlation. So I saw this evidence and I started measuring IgG levels to casein in my bipolar patients. Sample size is not that large, but all of them had fairly high elevated levels to casein. So we took away the dairy, and again, it's a small sample size, so I can't reach any strong conclusions, but all of them did much, much better when we took casein. But this opens the door again for a very safe alternative treatment, and also for us clinically to pull together observations and data to see if this is something that can really make a difference in bipolar disorder. So now I'm going to talk about treatments, and I don't have, again, that much time, so I'm going to talk about 3 things primarily.
You can have like 20, 25 more minutes if you want.
Okay,
You
well,
can have up to 10. You can have 30 more minutes.
okay, so I'll talk. So we're going to talk about 3 treatments primarily. We're going to talk about herbs, and then we're going to talk about minerals, which we already touched on, so I'll just talk a little more about that, and then food and exercise. So the first group of treatments I'm going to talk about are herbs that we call adaptogenic herbs. How many of you have heard this term adaptogenic herb? So quite a few of you. So these are herbs that were used primarily in traditional societies such as Ayurvedic medicine, Chinese medicine, and they were used by local healers or your family might give them to you. And they were recognized to help people deal with stress. So it might be emotional trauma or an infection or a period of excessive food deprivation, famine. So these were herbs that were used to help deal with stress. And I'm going to show you a list of these herbs, and many of you may recognize them. So there's Tulsi, which is used in Ayurvedic medicine. Ashwagandha is also Indian Ayurvedic medicine. Licorice root, Shisandra, ginsengs, maca. So there is actually a growing body of evidence of how these herbs help protect neurons, and some of them also evidence that they promote neurogenesis and may be helpful in depression. So if you go to PubMed, which is where it's a resource for scientific and medical studies, and put in the name of any of these herbs, you'll find at least 50, 100 to 300 different articles. Again, most of the research is done primarily on animals or in laboratory settings because there's not much money behind doing studies on these herbs in humans. But for example, rhodiola, this is an herb I often use. They found that in a rat model that the rhodiola improved serotonin levels in the hippocampus and induced neural stem proliferation. So it helped with the neurogenesis. And there's, again, many, many other studies on rhodiola. This is just a very, very short partial list, but it helps with mitochondria and ATP, which is involved in energy production. It protects against environmental toxins, and it protects against cell death of the neurons. This is ashwagandha, and this was a study where they looked at the antidepressant effects of ashwagandha compared to medication. And this is another herb. This is not an adaptogenic herb. This is another herb used in Ayurvedic medicine called bacopa, which has been used for a long time for brain conditions. And again, they found that it's neuroprotective and helps prevent against even things like methylmercury. So now we'll talk about minerals. So we talked about zinc before, which is very important, and I measure in all my patients, and it is often low. I haven't seen high as much, but I've seen low. But there are other minerals that are also important. One of them is lithium. So some of you may be thinking, lithium? Lithium is a really toxic drug which most patients who are prescribed want to come off of. Why would I talk about lithium, especially as an integrative doctor? So lithium, when it's used that way for bipolar patients, it's lithium carbonate used at high doses, like 600 milligrams. So at that level, it can be fairly toxic to the thyroid and the kidneys, and you get serious enough side effects that even patients who do well on it want to come off. But lithium may also be a trace mineral, something that we're all supposed to have at low levels. And this was an article in the New York Times, and it was written by a psychiatrist saying that should lithium be in the water? Should we all have some of it? Because there's more and more evidence that lithium may be neuroprotective. So some of the earlier studies on low levels of lithium came from the observation that in areas where there were higher levels of lithium in the water supply, there were lower levels of suicidality. And some of that data is inconsistent, but there's quite a few studies showing that there may be an association. And there's also studies showing that lithium protects neurons and promotes that BDNF, which promotes neurogenesis. So again, this is low-level lithium, and the low-level lithium is often used in micrograms rather than milligrams. And even when doctors such as myself use it in milligrams, we use it at much, much lower doses and different forms where there's no risk of toxicity. Magnesium. So this is another mineral that's often low in patients that I see, and there's evidence that that magnesium may have both antidepressant effects, and it may also help protect neurons. And magnesium is also depleted when you're under stress. So especially in this population where I practice, many of my patients are under stress, so magnesium is further depleted and can be neuroprotective. So why do we need mineral supplementations? Like, we didn't evolve to take supplements. Why would we need to take supplements? And there are quite a few reasons. So one, many of us don't have the ideal diet, which we would get all the minerals that we need to have a really resilient system. But even among my patients, and I think I have patients who are, it's a very select population. They come in, they're already doing many, many good things, and they have great diets. But even then, they may not have good levels of these minerals for different reasons. And they include, one is that we have decreasing mineral content in the soils. Minerals sometimes are wasted or out of balance due to stress or chronic infections. And then also we talked about genetic conditions and maybe certain SNPs that may affect mineral balances. So this is analysis of the mineral content in food, looking at calcium, magnesium, iron in cabbage, lettuce, tomatoes, and spinach from the period of 1914 to 1997. So you can see there's a drastic reduction. So in 1914, there was about 400 milligrams of these minerals, and now there's less than 100. So drastic. So even if you're going to the farmer's market every Saturday and eating lots and lots of vegetables and good food, you may not be getting the same minerals that your great-grandparents received. So then you could argue, as a society, are we less resilient? If we're not getting the minerals, if we have changes in the microbiota, are we less resilient in some ways to these things that affect neurogenesis? And now this is a study that came out of Harvard showing that, that rising levels of carbon dioxide also and global warming are also causing a reduction in zinc and iron and other minerals in our food. Okay, so we've looked at minerals, we looked at herbs, let's talk about diet. So often when you go see a psychiatrist, they don't spend much time talking about diet, but diet can have a big effect on our physiology and the brain. So ideal diet would increase resilience in the body and the brain. It would have things that support detoxification. So for example, cruciferous vegetables contain things that help detoxify. That's one of the reasons why they're so good for us. They can provide essential nutrients and building blocks. So they should contain things such as the amino acids to make neurotransmitters. The diet should contain the minerals that you need as cofactors. And an ideal diet would be anti-inflammatory and provide immune support. So certain oils that we eat can be anti-inflammatory. Now, a diet that's stressful, that can deplete the system and then also cause the loss of neurons would be something that could cause stress to the system. It could introduce toxins. So even thinking about something such as pesticides. Most pesticides came out of nerve gases that were created to act on the nervous system. And then we ingest them. And there are studies showing that people who are exposed to more pesticides do have more problems with things like ADHD and other neurodegenerative diseases. So a poor diet can also lead to nutrient depletion, such as low zinc, low amino acids, low fatty acids, and then you can also contribute to inflammation. So the example I had from the Hopkins study is that if your body is reacting to something like casein, that can cause inflammation, not just in the gut, but other parts of the body, perhaps even the brain. Phytochemicals. So we know that really colorful foods are good for us, and that's because these colors in foods help protect often the body, including the brain. So that's why you don't want a beige diet and just eating brown bread and white flour. So phytochemicals can be beneficial. We talked about cruciferous vegetables, helping with detoxification. And then the brain. So the brain is primarily fat. So you can imagine, what does a low-fat diet do? If you want to increase neurogenesis and you're not getting enough fats, which is the fad, what are you doing to neurogenesis? So one, you want a good amount of fats, but it's also the type of fats and how the fats are handled. So for example, the ratio of fats, if you have too much omega-6 and vegetable oils compared to omega-3s, that can promote inflammation. And then as a society, most of us grew up on having much, much more omega-6s than, again, our great-grandparents, because most of us, our great-grandparents, ingested and cooked in things that were saturated fats, like coconut oil, palm kernel, bacon fat, lard. That's what they cooked with, or butter. Those are all high saturated fats. But then in the 70s and 80s, the thought was, well, all of these are really bad. Don't eat them. So what did we start using? More of the vegetable oils. And now there's evidence that those vegetable oils, when they're out of balance, can promote inflammation. And again, we have to look primarily in the brain is mostly fat. And then other things that can promote neurogenesis include just habits like exercise. So it's found that physical exercise correlates with the gray matter volume of the hippocampus. Again, that's a part of the brain that's really involved in neurogenesis. So you can see how things such as diet and minerals and exercise can make a difference, and not just because we believe so or because our mothers told us so. There's good science behind it. There's really good science behind it. I think often patients who don't do well with these interventions are two reasons, and I'm going to get into both. So the first reason is that it's not just one of these things. To really have the ideal development, and this can be development of a child or development of the brain neurogenesis, you need to do many things. You would never do one thing and expect it to heal a garden. So if you were going to heal a garden, you wouldn't just go and just water it, would you? You would also look at things like the mineral content and the temperature. You look at all of those things and really tend to it carefully, I would say with nurturing and even love. And that's the way we should approach these illnesses. Second reason why some patients may not get better is it may not be enough. So the things I've talked about are all ways of strengthening the system, but if you have something that's really depleting the system, it may not be enough to do things like diet and exercise. And this is where it may be beneficial to meet with a physician who can test for underlying causes. And again, this list is incomplete, but the underlying causes can include things like hormonal imbalances. A lot of the hormones also act in the brain and are involved in communication in the brain. Microbiome disturbances, we talked about that, nutritional imbalances, chronic infections. I think this is vastly under-recognized in the field of psychiatry. There are many, many chronic infections that can affect brain function and mood. And especially in this, especially Lyme disease, because that's one illness that's often underdiagnosed and that we know can affect the brain and persist often. Toxicity we talked about, and that's hard to figure out because we're all exposed to so many toxins and often we can't measure them. Emotional stress, and then the genetics that we have, the genetic SNPs. So for the patients who don't get well, they usually need some type of assessment to look at these things and find what are the things that are really dragging down the system. And then also, I don't want to diminish the role of emotional stress and development. Those are crucial in all patients with depression. The reason I'm not talking about them as much now is I think for most of my patients, they've addressed that. They've looked at that. They've been in therapy. There's something else being missed. But for a patient who hasn't addressed those, it is vital to look at those things. What are things that have in the past caused stress or currently cause stress? But it's, I think with that more holistic model, looking at the body as a whole, looking at all the things that have influenced the stress response, that you can really provide hope to patients. So again, it's not all in your head. And with these illnesses, whether it's depression or anxiety, you really want to address the whole system. So I think I ended a little before time because I wasn't sure how much time I'd have.
Okay, questions? Yeah, questions?
Could you talk about sugar and what you see, where sugar falls in terms of inflammation, oxidative stress, that kind of thing? Just to what extent does that a factor in depression?
Well, it's hard to say definitively because we don't have great studies quantitating these things, but sugar can promote inflammation, and it can also change the microbiome in a very short period. So again, all of these things have multiple mechanisms where they're acting. And it's certainly one of the things where if I see a child or an adult who's eating a lot of sugar, it's one of the first things that we have to tackle, and for them to understand that if you're eating that way, just taking minerals is not going to be enough. And then it's also hard because your microbiome can also influence your appetite. So for some patients, it's really hard for them to get off sugar, so you may have to work on healing the microbiome before you can make huge changes in their appetite.
I saw the word microbiota. Is that the same like microbiome? I haven't known the word microbiota. Is that like the newest word?
No, I think there's just different, it's interchangeable.
Oh yeah, okay, thank you.
To what extent do you see undiagnosed thyroid problems as being an underlying cause for your patient population?
So that's a good question. So there's two issues. There's thyroid disorder and there's thyroid dysfunction. Okay, so thyroid disorder is usually picked up by most good primary care clinicians or internists. And that's where the thyroid, the TSH level, that's the screening test for thyroid, really falls out of the range or close to out of the range. What I see is a lot of thyroid dysfunction, where it's more subtle. And the thought was, well, if a thyroid is not higher than a certain value, it's not important. But in the literature, we know that in bipolar and depression, even these more subtle imbalances can cause an effect on the brain. So some of those patients may do well on medications. Other times there are even things like the ashwagandha, the herb that I mentioned, that can help balance the thyroid. Or there may be a deficiency. A lot of patients are now using sea salt and not getting iodine. Or selenium. Selenium deficiency can also impact how people convert thyroid into the active hormone. So it's often these disturbances that aren't picked up. And one of the clinicians I worked with calls this sensitive science. So we're looking for these things that, again, they're clinically important, but they're below the radar for many clinicians. So thyroid disorder, yes, can contribute to depression. I don't see that a lot because that's usually picked up. I see these more subtle imbalances that are harder to pick up but important.
We hear a lot about cell phones causing cancer and
Right.
and EMF, electromagnetic fields. But what I never hear is, what is the basis of that? I don't understand it. I worked in microwaves, and I think all that happens is it heats you up, but very little.
Right. So there, if you want to look at mechanisms, I believe the person who's done the best studies is Martin Pall, and he showed calcium dysregulation, that EMF seemed to cause calcium dysregulation. And calcium is really important in neurotransmitter communication. And so if you want to look more at mechanisms, you may want to look at his work. But he has...
Talk on it next month here.
There you go. So
Let me
it's
also-
eye-opening.
Let me also add that there have been some studies that have looked at subtle heating effects as they affect nanomolar receptor substrate interactions, that they're more sensitive to other tissue structures.
Right.
And that's why there's an amplification effect where very, very low power levels can have disproportionate effects.
I'll add one more comment to that too, and I think we have another one, is that it may be that those waves are interfering at the mitochondrial level, so very, very tiny elements. And that, you know how when you turn on your microwave and your microwave spins around, so on an average level, you may say that these waves don't create a heating effect, but for the same reason that you rotate your food, because the original microwaves would burn up some piece of it, they rotate it now. The same thing can be happening too, where you get a very concentrated peak somewhere very localized that disrupts something.
So I should change gears.
At the least.
Yeah, or hold it. Actually, the manuals all say hold it about 2 centimeters away from your head.
3 feet.
Yeah.
Suleiman in Turkey has done some studies where they put a cell phone on a pregnant abdomen and the offspring had brain changes. Hardell in Sweden's done a lot of research and showed that acoustic neuromas and brain cancers, there's a correlation. However, you'll never be able to prove this because how do you get a control? Because the cordless phones also affect it. So how are you ever going to get a control unless you go...
Rats?
Can
Pardon?
you use rats?
Well, unless you go to some place where there's no radiation. I mean, women have put their cell phones right here in their bras, and they've had tumors that outline where this phone was, and most breast tumors are not located right here. I mean, it's a lot of research, but like 60% of the independent researchers find that there's an effect, but most of the industry-funded research shows little effect. Now, this is like the cigarettes issue we had like 30, 40 years ago. The industry comes out and confuses us. They want to create doubt and confusion, and they're good at it.
We had a recent speaker, Dr. Deborah Davis. You can look in our archives and look her up and look, ehtrust.org is her website for that. Hot topic. More questions? Okay, right here.
I noticed that you talked a lot about the gut, but not the heart-brain relationship, heart to brain.
Well, I talked about that primarily for 2 reasons. One, I didn't have time. This was scheduled as a 30-minute talk, and there are many systems. And also, I don't really do many treatments for the heart. One thing that you may be alluding to is heart rate variability. Is that what you're, and heart math?
Yeah.
Is that specifically?
Yeah.
So that is a good way of assessing the system. But in terms of treating cardiac issues, that's not what we do. There is a relationship between the heart and the brain, and you see that, for example, even after heart attacks. And you can also see that in patients who have chronic illnesses, they have reduced what we call heart rate variability, which is the second-by-second variation in heart rate. So it becomes less flexible in some ways. So that is something that I encourage my patients to measure if they're willing to, because often it gives them feedback about whether they're in that healing state. And again, these things are, in some ways, they're more subtle. It's, if you're tending to gardening, you're not going to go watch it every day and look for things to grow. So I'm asking my patients to be fairly patient, but heart rate variability sometimes can quantitatively show an improvement, even before the patient feels it.
Yeah, because when you have increased coherence,
Exactly.
and 90% of your physiology is based on emotion.
Right.
And so if you're changing that, then, because I wasn't even talking about cardiovascular disease or thinking about that, I was thinking about psychological disorders, and particularly depression.
Right. No, you're right. There's a lot of literature on that, and it is an effective way of treating these conditions. I was just limited in time.
What about the role?
What do you think about the role of gluten in ADHD? There's a book written about it that my brother's been trying to get me to read because all of our kids seem to be, or a few of our kids seem to be, coming down with these diagnoses more frequently. Is there any evidence for that in your mind?
So I don't know if there's evidence, if you look at all patients with ADHD, that they're more likely to be reactive to gluten or improve. If you, again, use this approach, you can treat an individual. So I found patients who have more GI symptoms, who may have been on a lot of antibiotics, who may have elevated antibodies to casein, maybe children who will improve if you do a trial. The only way I think that we can currently know who's going to improve, whether they have ADHD or depression or chronic fatigue, is to do a really good trial and then re-challenge. Because all our testing is fairly poor, but the combination of the story and the testing can help us figure out who might benefit from a trial.
Thank you. I think I told him, I completely agree with you, and I told him I don't think the science is there yet to say that it's an absolute. You need a trial.
You need a trial, yeah.
Well, I think she means a personal trial.
Right, both, right, both.
Yeah.
Both.
Yeah, we do.
Well, gluten is highly inflammatory. It can cause dysbiosis, meaning leaky gut, and all sorts of autoimmune disease. And one of the theories behind depression is inflammation. And it's not going to help things.
So do we have evidence for the
Whole inflammatory diet being, there's a lot of different disease processes that seem to be influenced by this. And I'm just wondering, in your opinion, is there concrete evidence to substantiate that yet?
Well, for most of the interventions we're talking about, we don't have gold standard concrete tests. So as individuals, patients choose to take this on because other alternatives don't work. And for many of them, the idea of eating healthier or exercising is, fits what they think is a good way of living. I do think we need to do larger studies on this and collect data. And we're in a place where people collect data all the time. And I think that's something that we need to look at.
I think, let's see, do we have any more questions? I think, Robert, okay, back.
What kind of testing do you do as far as your practice goes to kind of determine some of the, issues with patients and stuff, laboratory tests or even symptomology?
So first listening to the story, and the story really can tell you a lot. And then the test, it's varied because, as I point out, there's so many things. And even from listening to the lecture before, I've learned new things that now I'm going to research and possibly test. But it involves blood test, urine test, stool test for the microbiome. This is an emerging field, so for many of the things that we're looking for, we don't have perfect tests, like even methylation. We have tests for methylation, but they don't always tell us what we need to do. And that's where we have to put together puzzle pieces, talk to people who are really intelligent, who've been thinking about this, and come together. The microbiome, we have some commercially available tests. Again, they're very limited, but they give us an idea of what's going on. But all of these fields, as people come to believe in them more, I hope we'll also have better tests.
So I can eat my yogurt and take my little probiotics pill. Is that a waste of time?
For what? Waste
To
of time?
maintain your microbiota?
So again, you have to think about, so probiotics, what a lot of people don't realize is when you take a probiotic, it doesn't colonize.
I know that just...
Right.
Yeah.
It just encourages the growth of the bacteria, so you have to have enough of your own good bacteria. But probiotics usually are something that can help with keeping that in mind. Yogurt, if it's truly fermented. So if you had the yogurt that your grandmother, for example, would have made and it was truly fermented, that's really good. If you get something from the grocery store, we don't know how many viable cultures, bacteria there are in it.
Those pills that have 10 billion.
Yes. Right. So, and then again, you have to make sure that you're not sensitive to dairy or casein. If you're somebody who's sensitive, that may not be the best, but there are other fermented foods, such as the kefirs and the kombucha and fermented vegetables, which can be helpful. Okay.
Okay, great, thank you. Thank you, Dr. Schwab.